Today is World Diabetes Day on November 14, 2024, and the theme of this day is breaking barriers, bridging gaps as a World Diabetes Day. And just wanted to discuss regarding diabetic foot ulcers, which is a preventable public health crisis. As much as these days are celebrated, we have to understand that it is not a celebration but reaffirmation of the the commitment of the world to taking care of removing barriers to healing to diabetic related problems. But we have to understand that every chronic disease prevention is an everyday issue, and without understanding that, these remembrance days or occasional days is not going to fix the chronic health crisis that we are facing. Hi, I'm Dr. Ravi Kamapali. I'm an infectious disease, wound care, and obesity medicine doctor at Regional Infectious Disease Infusion Center in southern Atlanta Market, Georgia. And our website is nobadbugs.com. Our X handle is at wound physician, and hashtag we use is removing barriers to healing. And disclosures include working on building a comprehensive telemedicine based solution for infectious disease, wound care, and metabolic health related complications in healthcare delivery. You have to understand that diabetic foot problems is a huge global burden, and obviously diabetes itself and is a huge problem. Other problems, but in the burden of disease, diabetic lower extremity related complications in 2018 ranked at 10. And we have to understand that every 1.2 seconds, people develop diabetic foot ulcers, and every 20 seconds, someone with diabetes undergoes amputation. So the outcomes in diabetic foot ulcers are needed to be addressed with 540 million or more people having diabetes worldwide, with 18.6 million having diabetic foot ulcers, and 1.6 million diabetic foot ulcers in USA, and lifetime risk of 34%, with more than 50% of diabetic foot ulcers becoming infected, and 20% of the diabetic foot ulcers leading to amputation, with 85% of all non-traumatic amputations being due to diabetes, and 50% of the people who suffer with proximal amputation lose another limb in less than 2 years. And every 3 minutes in America, a limb is being amputated because of diabetes. And this is some dire consequences we are facing because of this extensive epidemiological disparities and burden of diabetic foot ulcers, because we are not knowing how to address it and prevent it easily. But to address it and prevent it easily, we need to understand the etiology, epidemiology, and disparities in care delivery that are leading to significant problems with prevalence of diabetes, leading people having neuropathy, cardiovascular disease, kidney disease, retinopathy, causing 19 to 34% lifetime risk of diabetes, and 20% of the people with lower diabetic foot ulcer end up with amputations. And overall, the major problems with this process involves problems of vascular disease and also abnormal body composition, including patient having increasing problems with weight, with sarcopenia, and also excessive fat mass that is causing problem with inactivity, and also prior problems with people having foot at risk, including prior ulcerations and foot deformities, edema, and also calluses that form on the feet. And these leads to ulceration and leading to mortality because of infection and ischemia that form on the top of the ulcers, and leading to major and minor amputations. The problem that has to be addressed is also poor ability or access to the care and inadequate understanding because of recognition of the problem, which is an issue, and also cost factors and delivery of care processes where people are not able to know where to go. The problems with diabetes foot ulcers are significant, given that US annual diabetic foot ulcer disease burden is almost $15 million, with $15 billion, with more than 150K to 200K amputations going on, and most of them affect African Americans, as you can see, because of diabetes leading to complex disease processes. So there is increased burden on the healthcare delivery because of strain on healthcare, shortage of skilled professional physician burnout, and also increased government spending, social stigma and inequity of care, and also leading to loss of human productivity. And diabetic foot ulcers are compared to cancer in mortality. When compared, we have to understand that diabetes in general costs around $237 billion in 2017, whereas $80 billion is for cancer, and one third of these costs are attributed to lower extremity problems. The 5-year mortality rate for breast cancer is 9%, whereas for Charcot foot it is 29. For diabetic foot ulcer it is 30.5%, with basically minor amputations being 46.2%, 50% with the peripheral vascular disease problems, and 56.6% when there is major amputation. The 5-year mortality rate is so high. When compared to cancers, it is 31%, and when compared to breast cancer, it is only 9%. But lung cancer has higher mortality than diabetic foot ulcer problems. The major problem also is understanding the cost in the system. As you can see, the cost is increasing with diabetic foot ulcer in this study in 2013. But the problem is the ad hoc way in which the care is done, wherein patient is being taken care of at different settings, and referrals being made. But the process of having a team approach with patient in the center, having a limb salvage team with multiple specialists working towards one goal of wound healing, that needs to establish. And towards this end, I've been working hard, and in our practice, we're approaching this as a whole person approach in healing a whole person in a comprehensive manner that involves remote patient monitoring, chronic disease management, and also metabolic wellness with nutritional counseling and wound care. All these, including food tracking, glucose monitoring, blood pressure, and nutritional counseling on the remote and in person. We're doing in healthcare right now. There's a lip service in diet for diet to improve as an actionable step towards a high touch compassionate solution. Because the concept of diet versus disease is being replaced by drug versus disease, and the current medical practice where drug delivery is being used as a modality to improve the fat mass disease. And medical care deliveries, we have to understand, is more complex than building rockets, as we humans are unique, and unique kind of rocket each person. And medical care is needing a more than mass medicine mindset, as we have to deliver care processes wherein we should be able to find the people ahead of getting them falling out of the bridge into the water, and trying to lift them off the water downstream. So towards this end, I just want to share a few cases that we have done that you will give you an idea. And all these cases were done with the patient's permission and consent. So we are doing two parts of to help you. One is your wounds, that is a problem. I'm going to pull up your wound picture, okay? So we're doing a telemedicine visit on her. She's able to take her pictures at home. So the first picture that, are you seeing the screen?
Yes, sir.
This is the first picture we have. We did it in October 2nd. The wound is doing good, okay? And basically then you were home, and you took 4 pictures. So let's go to the initial picture that you took here.
Okay.
So October, yeah. So October 21st, okay?
Okay.
And October 25th, that one, and then October 29th. So basically, as you can see here, I'm able to see that. You see that on the 29th, you took a picture, and I was able to look it up. And if you see that there is that biofilm, there is a little bit of slime there, okay? Whereas in your initial picture, the one that you were when you came to the office, the wound was well granulated, and now, so without you coming to the office, I'm able to really assess it and see that there is slime. And now I'm trying to see if you can come so that I can take off that slime there. That will help. And by the way, the wound has improved when compared to before. There is this margin here. That margin is good skin that's trying to come through. Okay.
Okay.
So that's great. So has it been helpful that we have been doing this for you?
Yes, very helpful.
So that's good. So the other part that we are doing with you is the other one that we have, which is the one where we've been tracking your sugars. And how has that been?
It's been kind of hard because sometimes I forget to check it after I eat, or sometimes I don't eat. And so when I check it, I be trying to make sure that I'm getting you the results in good timing.
Okay. So basically, I see here one day you're seeing my screen here.
Yes, sir.
Your sugar here on one day was like 294. What did you eat?
That day, I took it right after, because that wasn't the right reading.
Okay.
Because I didn't eat nothing that day. And I think the number that came up behind it was 161.
Okay, that's better. So basically, what kind of diet were you doing? What have you been doing?
I've been doing the one you want, high protein, low carb.
Okay. So then that has improved your sugars there when compared to before?
Yes, sir, it has.
Okay. And I'm able to look at your medications and all. And what happened? Have you been able to take pictures of your food?
I took some pictures of my food. That's the only thing I think has been hard for me. Taking pictures of my food. When I remember to take the picture of the food, I take the picture of the food, and sometimes I forget. But I can tell you, in the morning time, I generally don't eat until about 12. Okay. So I drink coffee every morning. So I definitely have coffee every morning, and then I don't eat nothing until about 12. So
try to drink bone broth rather than all these crazy drinks. Okay.
Yes, sir.
That glucerna and all those, they have a lot of sugar in it.
Okay.
And then processed food, try to avoid the processed food. I'm seeing all those snacky foods. Okay. Try to avoid them, and then try to cut down milk on this coffee if you can. You can use heavy cream, but you don't want to put too much on it, and hopefully you're avoiding sugar in it. Good. So what was
you use heavy cream opposed to milk?
Yeah, little bit heavy cream, not too much. Okay.
Okay.
And then eating more protein. Okay. So tell me.
Yes,
Tell me, how were your sugars before all this? Before we met, how were you doing before that?
Before I had all that infection in my body, my sugars were good. I was at 6.7 at A1C, coming from 14. Okay. And then once I started having all the infection in my body, my numbers started climbing back up. And by the time the infection was gone, well, the surgery was done, amputation done, my numbers was at a 9. So I'll know my new numbers when I go to the doctor on the 7th.
I will possibly order some labs too, so you can do the labs, and we'll find it that you possibly are doing a lot better. So hopefully we'll be able to save this wound and leg. Hopefully we'll not have all this trouble. If you can I can work on trying to take off the biofilm on your wound. Make sure you document your food and glucose readings, and take pictures at dressing change, and those will come to me, and I'll be able to see it, and we can take care of it. Okay. So as you can see, we are doing as you can see here, we are doing two parts to help you. One is your wounds, that is a problem. I'm going to pull up your wound picture. Okay. So as you can see, there's a next patient is a patient we were blessed to take care of. Her being one of the patients, we were able to prevent amputation with her shortcut foot, but also in a Guardian article where we were able to show that most of the patients are losing limbs, but we worked hard to save it, and we did it with a comprehensive manner where we helped her even improve her sugar into normal ranges with dietary approaches helped her with the salvage of the limb. And complex wound care needs high-touch approaches. As you can see in this patient presents with UTI. Thank you for coming today. How are you? So who is this with you? Oh, your niece. I thought it was your daughter. My God, you lucked out there. Okay. So Tamika, tell me what happened to your aunt here?
She had a sore on her buttock in between, so it kept bleeding continuously. So we used gall method.
Yeah, but what made her go to the hospital initially?
I had a sore on my butt.
Oh, that's the reason why you went? Wow.
Mm-hmm.
I thought you... So,
I went for the sore.
Oh, you went for the...
But then when they got me in there, they said that I had
Okay.
a heart attack.
Mm-hmm.
And they saw me for when I got me up in the air. My blood work came back, said I had a UTI.
Okay.
And they started treating me for the UTI.
You became septic and all that. That's why they had a PICC line and IV antibiotics and all that.
Right.
Okay. So, how long has she had that sore?
Oh, it's about March or somebody.
Okay. So this is November.
Mm-hmm.
And basically, you ended up. When did they put the PICC line and antibiotics?
Like a week or two ago.
Mm-hmm. Okay, so
a week or two ago.
But so the sore was there since the March, but last month sometime you went to the hospital, and then they found her to be septic, and then they gave her the PICC line and IV antibiotic, and then outpatient they ended up sending her to me because of antibiotics and what. But I did not see her in the hospital.
You didn't see her.
Yeah. Okay. So the question is now, this sore. I just saw her. This is my second time seeing her.
Last week.
And so, what do you think I told you, and how do you think you helped your aunt?
I did everything you told me to do, and it's a whole lot better. It's look like it will.
Yeah. How did that happen? Huh?
I think they dry it. Yeah, what you said.
Yeah. The dryness. The dryness. So tell me, explain to me what you see in her butt. In the fold there, what was going on?
It was a sore, like
the wound was here.
It was open.
Yeah, and it was whenever she laid down, the wound
closed.
The buttock wound closes, and the sore was happening here.
So it wasn't getting no air.
It was not getting air.
Yeah,
it was getting moist.
It was getting moist.
So basically, they were putting you before you came to me. What you were doing?
Before we came to you, it was, what's that stuff called?
Yeah, foam dressing or?
Yeah, it was a foam dressing.
And it was keeping more moisture or less moisture?
More.
And then what we did kind of helped it a lot. And within, you took the pictures, so
in a week it was better.
It was better. So did she eat differently? Did she change the diet? Did you give her? Okay. Good. Okay. Basically, I want to show what we did for her. So basically, this is the application this is from today now, okay? This is the application that we give patients. We come here. And this application we give her, and then basically, patient is able to go and at home, she's able to take her pictures, and so basically, this is November 10th. And so, see that there? It was like that. You see the intergluteal fold. And November 7th. So, November 6th. So, she started taking pictures of the wound. And if you see here, the moisture, and she just was able to get the moisture better by putting just gauze in there. So, before that, she was using this foam dressing. And as you can see here, the foam was causing more moisture, but here with gauze, just plain gauze, the wound was improving. And then you see that the wound got better, and basically by November 9th, today is November 13th, 2024, by November 9th, within a week it got healed. So Moisture wound healing is very important, but here appropriate moisture, too much moisture is also causing maceration. So basically, by this simple approach, coccyx wound dressing, we were able to heal her. Thank you very much. So this another case series that we did. Now we presented at one of the conferences and as a where we retrospectively reviewed 20 patients who had a high protein nutritional approach to diabetic foot wound healing, using the platform based approach that empowers the patient with food logging and education to every patient with nutrition at each visit, and all those were tracked. We found 29 patients that received nutritional counseling. Of those, 11 were diabetic, 7 post-surgical, 4 venous, 4 arterial, and 2 traumatic. And in the diabetic patients were reviewed as those were the maximal number of patients, and there is standardized approach in diabetes. Wounds have to heal by 12 weeks. And we use that approach to try to assess if our nutritional compliance evaluations were working or not. Here we showed that when high protein, low carb approach was imparted on patients, of the 11 patients, the 9 patients weeks, the non-compliant and partially compliant, few patients took time. Where also the waist circumference improved. So waist to height ratio is very important, and waist circumference improved. That also is associated with improvement in nutritional compliance, showing improvement in medication reduction. So chronic wounds are a significant health challenge and often complicated by underlying metabolic dysfunction such as insulin resistance and glucose toxicity. Traditional approaches to wound care frequently involve high carbohydrate nutritional supplementation, which may exacerbate the metabolic issues and hinder the healing processes. And there is critical role of diet that in managing chronic diseases, and tailored nutritional approaches such as therapeutic carbohydrate restriction potential are improving healing outcomes, and the metabolic factors play a huge role. And approaches that focus on improvement of insulin sensitivity has to be the key in improving overall clinical outcome in diabetic foot ulcers. So when it comes to the prediction of infection using a whole person approach, that involves a comprehensive predictive analysis with rapid data growing data science. But also we have to understand that prediction and prevention go together, wherein we need to understand that to do this in healthcare, we need a right team and creating a right culture of change. So we need a team approach, and also identifying a well-defined use cases, and balancing big data with targeted approach. So we have to understand the population health, but also target healthcare solutions that are personalized. That is power of one approach. And integrating analytics into patient care workflow is key. And also the major aspect is driving adoption, which is painful. And this it's take a lot of effort and moving heaven and earth to try to collect data to make sure that the patients understand and the process improvement. With team approach, all this becomes easier. You have to understand that the current spectrum of care is in-person care, but integrating remote consultations, remote monitoring of blood pressure, glucose, and also remote monitoring, including food logging, glucose monitoring, and also wound picture tracking might be helpful in diabetic foot care with sensors, wearables, and telehealth technology that is available. This healthcare is going to be going into a next level of care in the future. Most important factor in wound healing equation is not just the nuances of care, which involve debridement, exudate management, infection control, bacterial films, biofilms, but also comorbidities, including nutrition and majorly access to care, and also understanding some underlying root cause healing with genetic testing or genomic testing and profiling that is coming in the future. But basic care is it can be delivered at scale at low cost. Healing the ulcer in a compromised host will need a real whole person approach to heal a hole in a person. And point of care solutions help, but we have to understand that patient centric, professional integrated process with technology and patient centric empowering solution is where real magic of healthcare happens, and adoption of healthcare happens with when the patient's education happens, and we need to improve the regulatory and compliance risks, and fragmentation of care has to improve, and user adoption and training has to change, and the cost of care and return of investment have to be understood, and we need to scale and evolve this process in a comprehensive manner. So, in the end game of medicine, we have to understand that fat mass disease plays a huge role, and understanding the lipotoxicity is a huge aspect in end organ damages that happen in diabetic foot ulcer, hepatic fatty liver steatosis, and diabetic neuropathy, nephropathy. And understanding that wound care is a wait and see specialty. In fact, all medical care is wait and see specialty. We need to track what we do, and the magic of medicine happens in follow up. The key is tracking and intervention and follow up again. And we have to move the mass medicine approach to a power of one medicine towards removing barriers to healing. Let's make every day a chronic disease prevention day. Feel free to reach out to us and our website, nobadbugs.com. And please, thank you for listening to the end. And hopefully, you like the presentation. Take care.